Welcome to the Lifestar Training and Education Center. My name is Todd, and I am glad you're joining me for this presentation. This is the November 2020 COVID-19 virus-free online edition of our monthly training. The topic for this month is EMS safe practices, which we are dividing into two broad categories. The first category is communication safe practices, and then we'll talk about medication safe practices. When we discuss the topic of communications for EMS, we're talking about not just the pre-hospital report that you call in by phone or call in by radio, but also the transfer of care report. And so we're going to talk about both of those communication environments. Communications is one of those things that you can just tell the more professional provider from the less professional provider. And I'm not talking about the difference between full-time career EMS people versus part-time and volunteer EMS people. It's much more related to how long have you been doing this, how many calls have you run, and most importantly, have you developed good communication habits? There are people that just press the button to the microphone and start talking before they've even thought about what they want to say. They give disorganized reports that contain information that's not necessary and fail to contain information that is necessary because they haven't developed those good communication habits. Then you hear the people on the radio who clearly have done this and give concise, thorough, relevant patient care reports that answer all the points that the person taking the report is listening for, and those are the more professional providers that I'm talking about. Communications is a critically important skill. Some of you are saying, but when I talk to the nurses, I can tell that they're not really listening. Well, that happens, and that's really on them, not on us. You can give a report in a way that is more likely to maintain somebody's attention, and we'll talk about that in a few moments. It is important to constantly remind yourself that bad communication at the wrong time in the wrong place can lead to very serious consequences.
She really taught me how to live and how to love in a way that I didn't really know before. We had a whole weekend planned of activities and making our way back towards the marina, and something went terribly wrong. There was a huge crash and everything went blank. Jennifer was thrown forward and crashed through the cabin door down to the lower galley, and I spent the night in the hospital myself, so I was unaware of what was really going on until the next day. That's when I learned she had a lot of continued complications with her breathing. We had gotten Jennifer to the place where she was now able to speak. She was able to write. She wrote in big letters that we're gonna make it. And at that point, I had every reason to believe that that was true. We were so excited because Monday morning she was scheduled for a barium swallow test. And that was the last big hurdle. With a green light on a barium swallow test, she was going to go home. I since have become very familiar with a term called TEF, which is a tracheoesophageal fistula, which is basically a hole that establishes itself between the trach and the esophagus. The barium went down her esophagus and then was quickly seen to migrate into her trach and then quickly spread into her lungs. They were blowing her full of air for 6 hours. Instead of it going into her lungs, it went into her belly. They told me that Jennifer was in cardiac arrest for over 14 minutes. She was so oxygen deprived that everything just shut. How is it possible that on Monday morning you have a definitive diagnosis of a TEF, but Tuesday afternoon she's back on a positive pressure ventilator with no isolation and no protection from that hole that they had just discovered? I've since learned a lot about electronic medical records and something that the industry talks about, which is the problem list. Problem list is a idea where you take all of this aggregate information and the computer systems try to organize it. The most problematic condition is sort of forced rank to the top, and then everything sort of in descending order follows thereafter. It's tricky, but it's where electronic medical records have to go, because no human can possibly absorb as they're coming onto a shift or as they're assigned a respiratory case like Jennifer's. I have 4,661 pages of her medical record. One page, one paragraph. Talks about the TEF. So what did the caregivers know at the most critical time? I don't know. They clearly didn't know she had a TEF. We all go into those environments with a false sense of safety. The truth is, there's so many moving parts. There's so much information. It's not well organized. It's not well communicated. It's not well coordinated. I don't believe for a minute that Jennifer's caregivers were intending to do any harm to her. It's just a case of they didn't know.
That's one very serious consequence of communication failure in the in-hospital environment. And communication failure is a critical mistake in patient care. It can happen in hospital, but it can also happen pre-hospital. And as pre-hospital providers, we have an obligation to make sure that our reports are as good as they possibly can be.
Call McLaren, call Medicare Alpha 107.
It's McLaren, go ahead, please.
Hey, McLaren, we got a priority 1 trauma for you. Let me know when you're ready to copy.
Go ahead, I'm ready.
I got a male patient coming in, mid-60s, I'm guessing. We got on scene, found the patient to be have agonal respirations. I had a sinus on the monitor at 68. This patient's got multiple injuries. His left leg is below the knee is fully degloved. He has several other obvious deformities as well. He's got blood coming from his ears. He's clenched at this time. I got blood pressure 155 over 117, 155 over 117. Still showing 68 on the monitor. O2 stats are 98%. He's being backed at this time. Continue further upon arrival. ETA about 5 minutes.
Very good, sir. Continue transport. We'll see you in 5 minutes.
Medicare Alpha 101.
Unit call McLaren, go ahead with the report.
McLaren, Medicare Alpha 101, en route with a priority 23030-year-old female. Patient, restrained driver involved in a motor vehicle accident. States she was barely moving when she was T-boned by another car traveling approximately 20-25 miles per hour. Patient complaining of chest pain, says she was hit with the airbag, side airbag, no front airbag deployment. She's A&O times 3, pain reproducible with inspiration and movement. No other, she's also complaining of some lower back pain, noted when she crawled into the passenger seat, no head or neck pain, no LOC. Blood pressure 137/83, pulse of 104 and regular, respiration's 18. Sinus check on the monitor, saline lack established, state 8 out of 10 pain. We're pulling into your facility right now. Do you require anything further?
Nope, see you on arrival.
McLaren McComb, MedStar Alpha 117, Party 1 traffic.
McLaren McComb, go ahead.
McLaren McComb, MedStar 117, Party 1 for a current 52, 52-year-old male. Chief complaint today, chest pain. Appears to be a STEMI. We did transmit you to 12 lead. ID number on that is going to be 1153. First 12 lead is a regular 12 lead showing STEMI. Second 12 lead we sent you is actually right-sided. That's B4R. It does appear to be a right-sided MI. At this time, patient is alert and oriented. Time is 4, GCS at 15. Vitals for blood pressure is 136, 136/98. Heart rate 73. Sinus rhythm on the monitor set 98%. Nasal cannula 4 liters. We have 324 aspirin on board, 2 IVs established. Going to administer nitroglycerin. Patient states left-sided chest pain radiating down to his left arm. 8 out of 10 now. State onset about 1:30 this afternoon. Only history is hypertension. If you're quite nothing further, we'll be there in about 5 to 7 minutes.
Can you ask the patient if he has a cardiologist, please?
Patient does not have a cardiologist. He only has a primary care doctor that he recently has no longer seen.
Okay, thank you. Let us know of any changes, and we'll see you upon arrival.
Every provider eventually develops their own style of providing a pre-hospital report, and it's very useful for the newer people out there to start working on whatever style they're going to use so that you can develop the muscle memory of doing a pre-hospital report the same way every time. If you're a full-time career EMS person, it comes sooner because you run lots and lots of calls. Many of them are lower acuity, so you get a chance to develop your report giving style. For those of you that are part-time or paid-on-call volunteer and working very low volume of calls, you have to work a little bit harder about developing that style of giving pre-hospital reports. The reason it's important to develop that muscle memory is because when you're on a very serious high-pressure call, you are most likely to revert to the style that you are used to giving. And if you've developed a style that's thorough, comprehensive, and detailed, yet to the point, you're going to be able to revert to that when the pressure is on. So you want to develop a style that is brief and to the point. It contains the pertinent information to make a decision about how serious this is. Remember that the person taking the report at the hospital is trying to figure out just a few things. How seriously ill or injured is the patient? What resources do we need to mobilize before the ambulance gets here? Do we have to call a trauma alert? Do we have to get CT set aside for an immediate CT on a stroke case or on a heavy trauma case? And what room are we going to put them in? Do they need to go to a trauma room? Do they need to go to a room that's a critical room where the nursing staff can see the patient and monitor them more closely? Or they can go to the room down the hall. It's a lower acuity call. It's, we're going to take care of this patient, but we're going to put them all the way down the hall because we have other patients that need to be monitored more closely. So they're trying to make those decisions based on your report. You want to make sure your report gives them the answers to those questions. You do not want to provide too much unnecessary information. They don't need to know that the patient had surgery 15 years ago for X, Y, and Z unless it's very, very specifically relevant to the chief complaint. They don't need a whole list of medications or allergies, just the ones that are pertinent to the chief complaint and so on. You just want to keep it relevant because this is a brief pre-hospital report where they're trying to answer just those few questions we talked about. You do want to mention whatever interventions you have performed so they can prepare for any other interventions that still need to be done. If for some reason you didn't do an IV, they need to know that they're going to have to start that sooner rather than later. If you didn't immobilize, they're going to need to know why, and they're going to need to prepare to immobilize cervical or bones or whatever. You want to give a full set of vitals, of course, so they know what's coming in, and then mention your estimated time of arrival. I like to start and end my report with an ETA. I usually start with, we are 10 minutes out with this patient, and then I end up saying, and again, we're 10 minutes away. These are all useful things that lead to good hospital report or pre-hospital reports. You want to avoid getting in the habit of giving bad pre-hospital reports, and the characteristics of these reports are usually a combination of either rambling, disorganized, unnecessary information, or some kind of attitude or behavior on the part of the person giving the report that's going to turn off the report taker and cause them to stop listening to the report.
Go ahead. This is Dr. Breen. Go ahead. We just got on scene for adult traumatic PMV. Unknown vitals right now. We just started CPR. Patient has 2 compound fractures on both legs. Patient's asystole, bleeding profusely from the face. We have not shocked yet. We are loading the patient out of the public right now. We'll have more to follow. But we've done about 2 rounds of CPR right now and suctioned about 200 milliliters of blood. Patient is still asystole. CPR is started right now. What was the mechanism? Patient was hit by a car. The legs are pretty much only attached by skin, open compound fractures again. We're working on IO right now. With an update when you get a chance, and we can talk more when you've got the patient out of the public's eye. Yep, we just loaded the patient in the back of the ambulance right now. Again, we're working on IO. Patient still asystole. We've done 4 rounds. CPR, again, major compound fractures, facial bleeding. I'll give you more updates. Sorry, we'll get vital signs shortly here. On scene. Sounds good. Unable to get an IO in both legs due to the open fractures. She has a dislocated right shoulder and looks to be another fracture in her left arm. Any concerns or questions on any other sites for IV access? No questions on IV access. I guess the question is, is she fixed and the patient fixed and dilated? Is there signs of, lividity, rigor mortis, anything setting in? No rigor mortis or lividity set in yet, but she's fixed and dilated. We're seeing no obvious sign or no signs of life, and we have multiple signs of pretty severe damage here as far as from the car accident. You're going to be in getting peripheral access, and quite honestly, from what it sounds like, I don't know even if you do get peripheral access, it's going to be of benefit to this patient from what we are describing. Okay, Doc, thanks. We just got an 18 in the left AC. We're going to push some fluid, see if we have good flow, and then we'll start ACLS, but again, we do not see any obvious or any signs of life here. From our previous stroke alert, we're now en route with a 5 to 6 minute ETA. We have a 9-year-old female with a 6-hour onset of stroke symptoms. She's positive Cincinnati with left-sided weakness, altered left-sided gait. She's got dysphagia and flaring as well. She's anal 3 out of 4 at this time, which is abnormal. We have her in an uncontrolled AFib between 110 and 160 on the monitor. We have a capillary sugar of 233. Blood pressure is 88 over 41. We have respirations at 20. SPO is 96% on room air. Do you have any questions?
You guys have an established IV that you can give her some fluids for that low blood pressure?
on a line, but we'll be there in 5 minutes. Any other questions?
Fortunately for everyone involved, there really aren't a lot of examples of really horrible pre-hospital reports. From time to time, you'll hear a very serious call going on, and you can tell that the person speaking on the radio is pretty flustered. And it's important that we take a little bit of a time out, take our own pulse first, and think about what we're going to say before we press that transmit button so that the report's going to come across professionally and effectively and contain the information that the hospital really needs. And as far as the number of times you hear real attitude on the radio, I admit the probability does go up when I'm working, but for the most part, you don't hear too much of that either. I would like to talk about trauma handoffs in particular, because this remains one of the most stressful kinds of reports that we give. And we'll talk about the missed trauma handoff and also the timeout or the stoplight technique that hospitals have begun implementing so that everybody is listening to us when we give that report. This remains one of the most stressful things for me, and I'm sure for a lot of practitioners, when you know that you are going to the trauma room and you see the entire trauma team standing and waiting for you when you go in, and you know that they're going to be listening to what is a very important report. I still will sit in the ambulance on the way down and dedicate a minute or two to organizing everything I'm going to say, making the notes on the things I know they're going to be listening for. So when I walk into this scene, I am prepared to give a solid trauma handoff report that is useful for them and makes us look professional. Let's talk about what I mean by a trauma call in a trauma center. Wisconsin has a trauma system, and they have 127 hospitals that participate in that trauma system. 13 of those are classified as level 1 or level 2, either adult or pediatric trauma centers. So we do have 1 and 2 trauma centers all over the state, but of 127 hospitals, only 13 are level 1 and level 2. And level 1 and level 2 are the trauma centers that you bring the very severe cases to. Level 1 is a hospital that's capable of providing total care for the patient no matter what is wrong with them. Whatever traumatic injuries they have, no matter how serious the illness, they have the ability, beginning to end, to handle that patient. So level 1 is the highest level and the most significant hospitals that we bring the oh my God cases to. Level 2 is the same as level 1 in terms of their overall capabilities. What's different between level 1 and level 2 is their research and teaching capacity. Now, I have been told that there are rumors that there are some other differences between level 1 and 2 traumas with regard to whether the team has to be on site 24/7 or whether they could be on a 30-minute callback for some specialties. The official definition in the Trauma System Registry is this definition that I'm giving you here, that the difference between 1 and 2 is research and teaching and nothing else. There is a possibility that there might be some slight bureaucratic differences. Those are really irrelevant to the patients that we bring in, and the specialties that might not be on 24/7 are not the level 1 trauma specialties that we worry about when we're bringing in our injured patient. Level 3 trauma centers have the ability to provide assessment and resuscitation and stabilization and emergency surgery, and then they arrange for a transfer to level 1 or 2 facilities for definitive surgical or intensive care. So they can provide trauma surgeons at level 3 hospitals under some circumstances. Otherwise, for the heavy-duty cases, they're going to transfer to a level 1 or level 2 trauma center. Level 4 provides stabilization and advanced trauma life support, and then transfers to level 1 or 2. The difference is they do not have the capability of providing an emergency trauma surgeon at any time. So the level 4 facilities immediately transfer anything that might require surgical intervention. Where are you going to bring your most seriously injured patients? This is an interactive map provided by Wisconsin Trauma Care System, which shows where hospitals are located and how they're organized. The state is divided into Healthcare Emergency Readiness Coalition, or HERC, regions. Let's take a look at where those regions are. Most of our business at LifeStar is conducted in the Southeast, South Central, Western, North Central, and Fox Valley regions. We do occasionally go to the Northeast and Northwest regions, but this is a pretty large area that we cover, and our Adams providers are smack dab in the middle of all of it and interact probably with the most regions than any other station. Let's put the trauma centers on the map here. And you'll see there are quite a few trauma centers rated from 1 through 4, with a few hospitals that participate in the system, but they are unrated in terms of levels 1 through 4. For the most seriously injured patients, we target level 1 and 2 trauma centers. I'm going to zoom in here a bit. And in Milwaukee, we have, of course, Fredert, and then there is Aurora Summit in Oconomowoc, a level 2. Down far south in Janesville, we have Mercy Healthcare, and in Madison, we have UW. Moving farther north and west, Gunderson is hiding here underneath this other center, so that's a level 2 trauma over there in La Crosse. In Neenah, we have Theta Care, and we have the Marshville Clinic here, and over in Green Bay, 2 level 2 traumas, Aurora Bay Care and St. Vincent's. We do have a couple others. Here is the Mayo Clinic over in Eau Claire, and then in Wausau we have Aspirus as well. You'd have to go past quite a few other hospitals to get to that one. And you need to make a determination whether you're going to go by ground or whether you're going to request helicopter transport. In my experience here in Ozaukee and Washington counties, we are so close to Fredert that by the time you request a helicopter, set up a landing zone, have the helicopter land, give a transfer of care report to the crew on the helicopter, and then inevitably it seems to me that they spend a lot of time in the back of my ambulance talking about things before they actually package the patient and go. If I had just started driving toward Fredert as soon as I knew where the patient needed to end up, I would be at Fredert before the helicopter would be landing there with the patient. So my experience with HEMS, or helicopter EMS, is I can usually drive faster than HEMS can get me there. But if you are over in the middle of Adams County, you're going to have a lot more trouble making that determination. You're going to rely quite a bit more on helicopters. What happens if the patient is pediatric? I'm going to zoom out again and watch for which of these trauma centers turn blue to indicate pediatric. Not much. Let me turn it off again and you can see again. We have Marshfield at level 2, and then we have Children's in Madison, Children's in Milwaukee, and that is it. A lot easier to make the HEMS determination with a child level 1 or 2 trauma than it is with an adult. So take all of this into consideration. Think about your transport time. Think about the amount of time it takes to get a helicopter to the scene, landed, transfer of care, packaged on the helicopter, and then back in the air in transport times, versus how much time it would take you if you simply started driving. You also need to consider what resources the helicopter adds to your trauma case. They do carry blood, and they are capable of RSI if you do not have a second paramedic with you. Other than that, most of what they add with regard to a critical care service like LifeStar is speed. They don't really add to the skill level, and they don't add to interventions other than whole blood. So consider carefully your decisions and make the best one for your patient. Once you get to the trauma center, then we run into the problem of giving an effective patient care report when the room looks like this. Very intimidating. Trauma centers do realize this, and many of them have implemented what they call a timeout or a stoplight system, where they have a rule about how long you can take to get the patient up to where the bed is, and then before you transfer the patient over, everything stops, and they listen to the EMS crew give their report. The idea is that there's just too much going on, and everyone's trying to do their particular part of the job. So you have techs and radiology people and nurses and pharmacy is there, and all these people are there, and they're all trying to get their particular piece of the puzzle taken care of. And they don't necessarily view it as important that they be the one listening to the report. They just want to get the patient over to the bed. They just want to get the IV started. They just want to get ready for radiology. So because of all this chaos and all these people standing around, they call a timeout where everyone stops and listens to the person giving report. The EMS crew usually is given either 30 or 60 seconds to give their report, and then another 30 seconds for anybody in the room to ask whatever questions they're going to ask of that crew. In order to make that 30 to 60 second report useful, they also are pushing for us to use what's called the missed report.
My name is Sherry Noffi, and I'm the Director of Patient Care for Loma Linda Emergency Department. Today, I'm here to introduce to you this fantastic process we've implemented, the Stoplight program. This is a program that we use to just pause for a quick second to make sure we're getting all the vital information from pre-hospital. Our trauma surgeons, our ED attendings, our nurses, and also the paramedics talk to get all the information they need from pre-hospital. This is allowing us to provide the best care for our patients and the best outcomes.
The Stoplight approach is basically an all-stop when we deliver a patient to the emergency room, so the staff could give their attention to the incoming paramedic to gain a good understanding of what we have done in the field for the patient and to deliver a better treatment overall in the emergency room.
The Stoplight approach is a way to improve communication. 20 seconds for the whole team to get into the room, which means, hey doc, it's time to come in, the patient's here, because there is sometimes when they're seeing other patients as well. It's a time whenever all of the providers get into the room at the same time. For the 60 seconds, it's time for the provider to give the information. Doesn't always take 60 seconds, but when it does, it's important to listen to the entire report and make sure that we understand what is happening with that patient. And that last 30 seconds to ask questions. So if anybody in the room does have questions about the care of the patient or what happened prior to arrival, that's our 30 seconds of wisdom.
This is Loma Linda Base.
Minutes down, we have a 22-year-old female. She's a Glasgow assist. She got called out to Apple Valley. Currently, she was the ATV on Hamilton, lost control about 30-35 miles per hour. Ended up end over the handlebars. Landed on her face. She does have some significant swelling to the right side of her face with a lot of abrasions. Unable to open her right eye. Apparently, for bystander, she was out for approximately 1 minute. That didn't come to. She had a total of 2 episodes of LOC before she spent in Glasgow of 15. Does have some alcohol on board. She also does have some abrasions to her chest and also her right arm.
Alright, before we move the patient on the bed, we need to stop for a report.
She's 22, coming from Apple Valley. So per EMS, she was actually riding a quad. She was non-helmeted, lost control of the quad. About 30-35 miles an hour, ended up end over end. So she landed on her face. Positive loss of consciousness. She's got a significant amount of swelling to her right side, unable to open her right pupil. Right. I also unable to really open her mouth to really assess her dentation, but she's been alert. Per EMS, she did have a positive LOC. She was out for approximately 1 minute.
Okay.
She had 2 episodes of that. She does have some ETOH on board. She's able to maintain her airway. She does have some abrasions to her chest and right arm, but everything else is unremarkable. Stable pelvis, belly's been soft, clavicle's been equal to palpation. Sugar was 111. She's got 2 IVs, 220 gauges for you guys. No history of meds, allergies. So.
What was her last blood pressure about?
141/77.
Was she tacky at all?
Nope, not tacky at all. Yeah.
So there's an initial loss of consciousness, and then they said that there's another loss of
Yeah,
consciousness?
so she had a total of 2, and each time lasting about a minute.
And this is so during your guys' transport? Then?
No, she's been alert for us.
Okay.
Yeah.
All right.
So no complaint of pain upon palpation to the pelvis or anything like that. So.
Okay.
Any other questions?
No. 1, 2, 3.
This IV came out over here. Okay.
Before Stoplight, it was you just have so many bodies in there, and everyone starts trying to put the patient on the bed, and everyone's doing their own thing, and it gets really loud. It gets very noisy in there, and a lot of the times the medics would have to almost scream over all the other stuff that was going on in there. So what would happen is a lot of times the medic would just step out or move away because obviously it didn't honestly sound like they were being listened to sometimes.
The benefits of Stoplight approach is to let the AMR or Mercy Air give report and not get interrupted in between all of us doctors, nurses shouting out questions about the patient, and it just gives them some time to get their whole story out before they leave and we know the whole story.
I think the most beneficial thing of this program is a streamlined process when it comes to giving a report.
Helps improve communication in the emergency department.
I think communication definitely has improved. We're able to get a painted picture of what happens in the field, which is very important for us to know, and I think things aren't getting missed that may have been missed before.
I mean, there's been times in the past from other hospitals where they missed a certain laceration or a entrance wound or something like that, and they'd miss it on the head, and they're like, hey, how come no one told me? I was like, oh, the medics gave report to one person, but then no one else heard it.
It definitely has helped communication, and what it does is it just shows a mutual respect for that report and how valuable it is to us as hospital providers and for EMS to give us that report. It's important to hear what they have to say in regard to the patient, and again, it's patient-centered, so that's where we want to go with this.
What I dislike most about the Stoplight approach is the fact that it takes more time to get into the patient care. If we were to have maybe one person instead of 10 people working on a patient at once quietly while the medic is giving the report, I think it would work a lot better instead of having no hands on the patients for that duration of time.
Closed loop communication, that's what I would do to improve it, is when someone says something, someone verifies it. Someone says it, clarifies it, or read it back to you. That way everyone knows what's going on as far as giving a medication or even an assessment. Like, those are very important.
Some of the areas of concerns that come to mind would be maybe just it's a new program, it's not the norm. I think some of the staff may not be used to it, and their reaction is wanting to jump in and do work. And having to have that moment of silence to listen to the pre-hospital personnel is new, so that's going to be a learning curve for everyone, pre-hospital and emergency room staff.
I actually don't dislike anything about the Stoplight program. I think it's a great thing. I have seen it improve communication and relationships between both sides.
I don't think I need to have the power to improve communication. I think it's already given to us, and it's in each one of us individually. And I think that's the biggest reason, and I said this before, but that's why we were given 2 ears and 1 mouth, because it's more important to listen than it is to talk. We lose information if we continue to talk over people, and we will actually gain more information if you just listen. I am a perfect example of somebody that talks way too much and doesn't listen enough, but it is one of my goals as a person to listen more.
The flip side of the agreement where everybody in the trauma room stops what they're doing and listens to what you have to say is that we have to agree that what we say has value and makes it worth their time to stop and listen to us. So trauma centers around the country, and I know Frederick for sure is one of them, has adopted this idea of using the MIST mnemonic in order to organize your report into the most useful information. So starting with a trauma call for MIST, M would be the mechanism of injury. Is it a motor vehicle accident? How fast were they going? What kind of damage to the car was there? Where in the car were they? Were they restrained or not restrained? Everything related to describing the mechanism of injury for a motor vehicle accident. Did they fall from a height? How high was it? What were they doing up there? Were they on a ladder? What kind of surface did they fall to? Everything related to the mechanism of injury. Then moving on to I for the injuries identified would be either a list of the injuries of which you are aware in order of importance or a head-to-toe trauma assessment of the patient, starting at the top of the head, working your way down the body, all the injuries of which you are aware. For signs and symptoms, you want to give an obviously a comprehensive set of vitals, including a Glasgow Coma score or a revised trauma score or both. And then T would be your treatments, whatever interventions you have performed. What have you immobilized? What IV access have you established? What medications have you given? And what were the responses to those treatments? Then I would suggest a good idea is to end your MIST report with the phrase, "Any questions?" That way the whole team knows that you have stopped talking and it's time for them to ask whatever questions they still have for this report. When it comes to a seriously ill patient, the MIST can also apply there, where M becomes the medical complaint. What exactly is it that they are complaining about that brings them to the ER? So altered level of consciousness, difficulty breathing, chest pain, or whatever it is. I would be identifying the illness that would expand upon what their medical complaint is to any identified illnesses. So if it's an interfacility coming from another ER, what have they established so far? What do they know about the blood work? What do they know about any imaging that was done, CT scans and x-rays and so on, and identifying that illness, specifying and expanding on the medical complaint. The next two sections, signs and symptoms and treatments, remains the same. And then again, I suggest you end with the phrase, "Any questions?" so they know that you've stopped talking. A lot for you to think about when it comes to effective communication and giving good reports. The second half of this monthly training is going to focus on medication safe practices, and that will be contained in a second video. So I thank you for joining me, and we can move on to the second video when you have time.